Hi everybody, we are going to talk about the non-immune hydrops, the NIHF here. I am going to explain it clinically with some theoretical aspects of it. I think my approach here is useful for pediatric residents. So I have read Cloherty for neonatology and made these notes. I have written the definition, etiology and pathophysiology of fetal hydrops on one screen. I am not going to talk here in detail about the pathophysiology because after all it's for postgraduate residents. So as you already know that we have to think about the disease very quickly as a resident, you must read it by yourself as I do not want to prolong this video by explaining those aspects. I request you to please take time and read it thoroughly before proceeding to the next. I have also used some abbreviations here and I put those in the description. In case you don't understand, then read it there. Another thing I have to tell you is about the mirror syndrome, which is the life-threatening maternal complication of fetal hydrops. I will explain it in my next video along with some other maternal complications of fetal hydrops. In this video, we are going to discuss basically the evaluation of the disease. So let's divide it into two parts. First of all, we are going to look at the maternal side, and then I am going to summarize prenatal and postnatal evaluation on the fetal and newborn sides, along with some management guidelines. In general, we have to first rule out immune hydrops by from NIHF by ordering CBC blood group and a Coombs test. If it is ruled out, then we are going to run an algorithm for NIHF. So let's talk about the presentation first. Have a look at the table. If the mother presents with fever, joint pain and rash, then we have to think of parvovirus infection as a cause of NIHF. We should also keep in mind that one-third of cases of parvovirus infection have no symptoms at all. If the mother complains of decreased fetal movement, rapidly increasing weight, or abdominal girth, then we should suspect polyhydramnios. It is the most frequent finding associated with NIHF as per the definition. If there is a previous history of stillbirth or hydropic fetus, then lysosomal storage disease may be responsible for NIHF. And suppose we are evaluating maternal anemia, and if we find MCV, means mean corpuscular volume, less than 80, pointing out microcytic anemia, then you have to make sure that the mother has a history of alpha thalassemia or not. This is going to be more common, particularly in the South Asian descent. So now I am going to talk about the fetal side. As shown in the algorithm, if we find fetal hydrops on routine ultrasound, then we are going to do a comprehensive USG. MCA means middle cerebral artery Doppler and fetal echocardiography. As described in the previous table, cardiovascular causes are the most common ones. So if fetal heart rhythm shows SVT or atrial flutter, then we should immediately give digoxin followed by flecainide or sotalol to the mother. Although bradyarrhythmias are associated with NIHF, particularly ventricular beats less than 50 or the presence of anti-RO bodies are not amenable to any treatment. If you find any SOCL like CCAM or CPAM, means space occupying chest lesions on USG, or if we find twin to twin transfusion syndrome on USG, then we should consider referral for surgery. If the MCA Doppler shows PSV greater than 1.5 multiples of median, means peak systolic velocity, then we are going to check for fetal anemia. And for that, we have to rule out maternal parvovirus infection by doing serology. And also, we have to rule out feto-maternal hemorrhage by doing KB stain, means Clehor Bedke test. If a parvovirus infection occurs prior to 20 weeks of gestation, then it is associated with profound fetal anemia. And the presence of hydrops is more likely to increase fetal loss. So we can diagnose parvovirus infection by doing a maternal antibody screen and confirm it through PCR of amniotic fluid, which is diagnostic in 24 to 48 hours. We can do that by chordocentesis and manage it by giving IUT, means intrauterine transfusion or packed RBC. If umbilical venous pressure is elevated at the time of chordocentesis, it indicates inadequate cardiac output as the cause of NIHF. Normalization of the venous pressure after correction of the fetal condition invariably resulted in perinatal survival. Let's look at the other side of the evaluation. If MCA Doppler is normal, then we are going to suspect syphilis and torch infection as differentials. We can check syphilis through rapid plasma reagent test, and if RPR comes up negative, then we can ask for a maternal history of previous stillbirth or consanguinity to rule out autosomal recessive disorders like lysosomal storage disease. We should also consider amniocentesis as the final step for fish and lysosomal enzyme assays. Uh, okay, now let's dive into some important management guidelines according to Cloherty, which I have summarized in a simplified way. Uh, Management according to etiology. If we focus on the determining the etiology, then it will increase the chance of perinatal survival by giving in utero therapy. If we detect mirror syndrome earlier, then delivery is the best option. Uh, if findings of trisomy 18 or severe Epstein anomaly may there, then they warrant consultation with the palliative care team because prolonged survival after birth is unlikely. In cases of idiopathic NIHF, perinatal mortality rates approach 50%. Fluid management. The hemodynamic instability is common due to rapid fluid shifts secondary to extravascular fluid drainage as a part of initial resuscitation for management of pleural and pericardial effusion, and also the presence of hypoalbuminemia and hypoproteinemia may be responsible for hemodynamic instability. Patients with heart failure frequently will suffer from respiratory failure, anemia, hypoproteinemia, metabolic acidosis, hypotension, oliguria, and pulmonary hypertension. Fluid management should be based on a calculated dry weight of the patient, usually the 50th percentile for gestational age. Maintenance IV fluids should start at 40 to 60 ml per kg per day of 10% dextrose solution and also adjusted for serum glucose levels. Most hydropic infants are normovolemic, and so care should be taken to not to volume overload if there is evidence of cardiac failure. Free water and salt intake should be restricted in the first few days because these patients have high extravascular salt and water content. Use of diuretics should be cautious and include frequent electrolyte monitoring. Euvolemic partial exchange transfusion should be considered in the anemic heart failure patient, means hematocrit less than 30% to improve oxygen carrying capacity and increase hematocrit. Finally, these are images describing the effusions through ultrasound. In the figure 5.1, there is a scalpedema and ascites. The scalpedema, as you can see, the small arrow indicates scalpedema and large arrow indicates ascites. In a case of NIHF secondary to parvovirus at 22 weeks gestation. As you can see in the figure 5.2, large left-sided pleural effusion uh, in a fetus at 28 weeks of gestation with bronchopulmonary sequestration, a lesion indicated by a star in the image. Also in the figure 5.3, there is a pericardial effusion in between the arrows in a recipient twin with severe twin to twin transfusion at 24 weeks gestation. And lastly, in figure 5.4, there is a placentomegaly in between the arrows at around 25 weeks gestation associated with NIHF in a fetus with an unbalanced atrioventricular canal defect and heterotaxis syndrome. Heterotaxis syndrome, I don't know about that. You can Google it. So we can conclude this topic. So if you really like this video, then share it with your friends and